apologies, Echo team, we cannot get your audio.
Hello. Hello. Okay. Thank you, Dr. Mtete. So today we'll be looking at our objectives will be two main ones. The first one will be to discuss some of the salient features that we need to look out for when we're taking a history, and then some of the features to look out for in the physical exam that would sort of point us to suspecting that a patient could have a secondary headache. Then there's quite a number of secondary headaches, but I only picked out three that we're going to look at today. Okay, so I'll hand over to Teresa to launch our first poll question.
So this is our first poll question. I would like to encourage you to participate, and just to remind you that the answers that you'll be sharing, we're not able to see who's answered what exactly, but we encourage you to give it your best shot. So the first question is, the following are secondary headaches: A, migraine headache; B, tension headache; C, cluster headache; and D, none of the above. I'll read the question again. The following are secondary headaches: A, migraine headache; B, tension headache; C, cluster headache; D, none of the above. You have a minute to answer the question. All right, so far, I'm very pleased with the response. We have at least 56 participants, 56% of the participants answering. We encourage you to continue answering. Thank you so much to everyone who's responded so far. You have 20 seconds remaining. All right, 5 seconds. Okay, thank you so much to everyone. I'll hand it over to the presenter.
Okay, so I think these are the responses that we've received. About 21% going for migraine, 14% for tension, and 4% for cluster, with the majority of 61% saying none of the above. Okay, thank you. So we continue with the presentation. From last week, we did discuss that in the brain, essentially only certain tissues are able to perceive pain, or they're the only ones that are capable or have the receptors to perceive pain. So a headache would generally arise either from the meninges, the blood vessels, the nerves, or the muscles. And so when a patient comes in with a headache, you're essentially thinking about something in those particular tissues. Of course, the neurons themselves may not perceive pain, but if there is mass effect and the meninges or the blood vessels are involved, then the patient will come in with a headache. Your goal essentially when the patient comes in is to pretty much delineate between two things. Is this a primary headache for which we may not identify a cause, or is this a secondary headache for which definitely does have an identifiable cause? According to the International Classification of Headache Disorders, this is the 3rd edition. The secondary headaches are grouped in these different groups. So you could have a post-traumatic headache that would be classified as a secondary headache. If you were involved in an accident or you had trauma from any injury and you develop a headache afterwards, that would be a post-traumatic headache. It could be vascular. So let's say blood vessel ruptures, or a patient has a stroke, that is a secondary headache. For other intracranial pathologies, could be things like tumors that are developing in the brain, substances. I think 2 weeks back when we were looking at primary headaches, we did talk also about medication overuse headaches, which come up from taking a lot of painkillers. Those could also be classified as secondary headaches. People who abuse drugs, taking cocaine, all those would be secondary causes. For infections, we know patients coming in with the meningitis, be it TBM or cryptococcal meningitis, they may come in with headaches. Homeostatic disorders, for example, if you're going to climb Mount Kilimanjaro and as you go up, as the oxygen tension reduces, you end up developing that acute mountain sickness. Presenting with a headache, that would be a homeostatic headache, which is a secondary headache. And then think through some of the structures that we have. So you could have pain from the eyes, you have things like glaucoma, or patients who have chronic sinusitis, you have a dental root abscess, all those are causes of secondary headaches. Then we also have those that we may not be able to find any organic cause. So the ones that we call somatic headaches, which are classified as psychiatric headaches. And you could have neuralgias, especially those coming from, cranial nerves. So when you're taking a history, today we'll focus more on what to look out for a secondary headache. We did go through what we need to look out for primary headaches, but I'll try and tailor our history taking for a secondary headache. So we always want to characterize the headache, and it's everything that we have learned from medical school using the Socrates criteria. You want to define where the site is, how does it start, how's the onset, what's the character of the headache. So suffice to say, you could describe it as a dull, throbbing, or tightness, but this is not or does not well distinguish between the different types. We know that throbbing headaches could be arising, for example, from a blood vessel, but you could have a tumor also giving you a throbbing headache. It is important to characterize the headache because sometimes we want to know if the character is changing over time, and that's why it's important for us to describe the character of the headache. You also want to know where the headache is. Is it a frontal headache? Is it on the sides? Is it an occiput? Is it a global headache? Is it happening only on one side of the head? So give a good description of the headache. Then you also want to find out if there are any other constitutional symptoms. So let's say the patient also has weight loss, they're having night sweats, they're having fevers, that will already start pushing you probably towards an infectious process. Is there any visual disturbance? So you would be thinking, is there anything causing an increase in pressure, or is this visual disturbance just from the eyes themselves? Is there pain when they're exposed to light or sound? Is there associated nausea or vomiting? All these will push you towards thinking of a probable secondary headache. You could have some of these features in a primary headache as well, but there are also more important red flags that are telling you to say there could be a secondary headache. Then in terms of the acuity of the headaches, so most patients who have primary headaches have probably had them for some time, so they'll tend to be chronic. But if someone comes in with a new headache just over a short period of time, you could start suspecting that this could be a secondary headache, especially in someone who previously was not known to have any headaches. Then as you ask the questions, try to see if there are any precipitating factors. So before the headache started, were they having any fever? Were they having any general body weakness? Is the headache coming up with change of posture? For example, they'll say, well, I have the worst headaches early in the morning, or my headaches are when I bend down or when I lie flat, or when they're bearing down, for example, coughing. All that would sort of point to a probable secondary cause. The tempo, essentially, we've spoken about how that, depending on the onset and timing as well, what time do they have their worst headache? And when the headache starts, how long does it tend to last? We know with primary headaches, these will occur with time, and probably they go to sleep, and as they wake up each day, it's either the headache is getting better. But if the duration of the headache is a very constant headache, it's lasting for a longer duration of time, doesn't seem to have patterns, all those will sort of point you towards possible secondary headache. Then you also want to find out what makes the headaches worse. So if there's pressure increasing in the brain, simple things like sneezing or coughing would also sort of worsen the headache. So you ask for such factors and then take a good history also to find out if in the past they've been having any headaches, and then try and compare the character of their previous headaches to the headaches they're having presently. For a medication overuse headache, we know that some patients, when they have a headache, they'll start taking painkillers and they may be taking them every day, which puts them at risk for a secondary headache. So someone could have a headache, maybe primary or secondary, but they could also have an overlay from the medication overuse headache. So do take a good history of which painkillers they are taking and how often they are taking and for how long they've been taking them. Then your differentials also, as you're taking history, will sort of depend on the type of patient you have before you. If it's an immunocompetent patient, let's say someone who's HIV positive, or they're on steroids for some autoimmune condition, or they may have a malignancy, so you know that the immune system is suppressed. There's possibilities that they could probably have CNS opportunistic infection. So you want to know, is this patient immunocompetent or are they immunocompromised? Find out if they've had any malignancies in the past, because a new headache probably in their setting could be possible metastasis. See if they're on treatment for any autoimmune or inflammatory conditions. Let's say someone who has SLE later on could have CNS lupus. So you want to take a good history of their comorbid conditions. Then find out if there's any family history of such headaches and if they are currently abusing any substances. I'll hand over to Teresa to launch our second focus.
Right. Before I launch the second question, I just want to remind you, if you have any questions or any contributions, you can feel free to type them out in the chat box. So our second question reads, a new onset headache disorder after the age of 50 is more likely to be a primary headache disorder. True or false? A new onset headache disorder after the age of 50 is more likely to be a primary headache disorder. True or false? Okay, you have less than a minute now to answer the question. Okay, so far we have at least 58 participants answering. Okay, 10 seconds. All right, I'll end the poll now. Thank you so much. Okay, so for those that answered true, we have 18%. And for those that answered false, we have 82%. I'll hand it over to the presenter now.
Okay, thank you, Teresa. So quite some interesting results, and it's always good to have your participation. Okay, so just to sum it up, to make it easy as you're taking history or as you're examining a patient, there is this mnemonic, which is SNOOP P4. So the S standing for systemic symptoms or secondary risk factors. The N is for neurological deficit, onset, and order age, and then we'll go through what the P4 are as well. So if you have a patient who's coming in with a headache and some of the associated features of that headache is that they're having some fever, there's some weight loss, there's some night sweats, that should push probably you to a possible cause as being an infectious etiology or a giant cell arteritis. If the patient has a secondary risk factor, let's say they're HIV positive or they have a cancer, you'd start thinking of metastasis, possibility of CNS opportunistic infections. If they have a focal neurological deficit, let's say they have weakness on one side of the face, or it can be weakness of the hand, or it's just loss of sensation over a specific part of the body, or indeed they're, let's say, altered, they are confused, that should also push you towards thinking that this could be a secondary headache as opposed to it being a primary headache. In terms of onset, one thing that's more important to talk about is a thunderclap headache. So the thunderclap headache, essentially, this is a patient who's coming to you and telling you that they had, from the onset of the headache, within the first few seconds or just first few minutes, the headache was at its maximal point. So most times when patients are describing this to you, they will actually say, I felt like I was hit with a metal bar on the head. So that's a thunderclap headache. That is a secondary headache, and there are quite a few, well, a lot more causes of it. Thunderclap headache, the most common being a subarachnoid hemorrhage. So let's say they have an aneurysm in the brain and that ruptures, or they bleed into the pituitary gland, or if they have risk factors for forming a clot in the sinuses, they could have a cerebral venous sinus thrombosis. Thunderclap headaches would definitely or should definitely push you towards thinking that this is a secondary headache, as opposed to it just being a migraine that you should probably not get any imaging for. And then older age. So for someone who's not had any prior history of headaches, any new headache in an older patient should push you towards thinking that this is a secondary headache. And in the right clinical setting, could actually be that they have a developing mass or a tumor, or they could have the temporal arteritis. Then if the headache also changes with posture, so this is a patient who's telling you to say when they bend down or when they're using the bathroom, when they cough, when they wake up in the morning, they have very bad headaches, that should point towards a secondary headache. If the pattern has changed, let's say this is a patient who previously used to have migraine headaches, and then over time, they just feel that the character of the headache has changed away from their previously non-primary headache, you should suspect a secondary cause. If it is precipitated by bearing down, so Valsalva maneuver, or coughing or sneezing, that is a secondary headache. And if there's facilities, or if you are able to do a fundoscopy and you find papilledema, that will also point towards a secondary headache. In terms of the physical exam, so you look at the vital signs, so what's the BP, what's the pulse, what's the temperature. You could get some vital information from there to tell you, is this from an infection or not? If there's scalp tenderness, that will make you think of a giant cell arteritis. If there are any neck features, so let's say neck stiffness, or they have paraspinal tenderness or spasms. So with signs of meningism, we know that it could be from an infection, but from a subarachnoid hemorrhage, as you have blood into the subarachnoid space, patients may also come in with neck stiffness. So you also want to take a good description of their mental status. Are they confused? Okay, are they oriented? So that will also give you some vital information when you're trying to delineate between primary or a secondary headache. Then if you're able to do a fundoscopy, or you have ophthalmology to assist, they could do a fundoscopic exam for you. And if there's papilledema, that would point towards a secondary headache. So in terms of extraocular movements, I think in one of the other sessions when we're looking at examination or a neuro exam, we know that you have the patient look in different directions. If they have any limitation in their extraocular movements, and the most common being if there's any increase in pressure, the 60th cranial nerve is the one that's commonly affected. So remember, the 60th cranial nerve helps us to look sideways. So for the right eye, if you're looking to your right, that's your 60th nerve. For the left, if you're looking to the left, that's your 60th. So if there's any limitation in that, that should make you think that there's probably something that's raising pressure in the brain. And then, of course, if they have any unilateral weakness or unilateral loss of sensation, that also adds to the thought that the headache could be a secondary headache. In terms of treatment, the reason why we want you to characterize any red flags is that it changes the management or your approach to management altogether. Remember, for primary headaches, we say someone with a migraine or someone with a tension type headache, you do not necessarily need to do any neuroimaging, and you may not even you're not required to do a lumbar puncture. But for someone who has these red flags, your approach to management will start with investigations. You first do your brain imaging, and thereafter, if a lumbar puncture is indicated, you're also going to do a lumbar puncture. So we'll look through a few of these secondary headaches. We just picked out a few. We'll discuss these after this poll question. Over to you, Teresa.
All right. So our third poll question is, okay, so before I just read the poll questions, I just want to check on the chat. All right, okay. So our third poll question reads, which of the following is a more likely cause of a thunderclap headache? Which of the following is a more likely cause of a thunderclap headache? A, subarachnoid hemorrhage. B, meningitis. C, migraine headaches. D, brain tumor. Which of the following is a more likely cause of a thunderclap headache? A, subarachnoid hemorrhage. B, meningitis. C, migraine headache. D, brain tumors. Okay. Thank you so much for those participating. We have now at least 10 seconds till we close the poll. All right, I'll end the poll here. Thank you. So we had 90% responding to A, subarachnoid hemorrhage, 5% responding to meningitis, 0% for migraine headaches, and 5% for brain tumor. Thank you so much.
Okay. Thank you for that. So we're going to look through just three secondary headaches. So the first one is a subarachnoid hemorrhage. So this essentially is where we know we have three layers or three linings of the brain, the dura, the arachnoid, and the pia mater. So in the subarachnoid space, if there's blood, could either be a spontaneous bleed, let's say from rupture of an aneurysm, or it could be a traumatic bleed. Okay, so it can also be a bleed from an AVM or an arteriovenous malformation. There's no gender predilection for subarachnoid hemorrhage, so it occurs the same in both genders and is more common in the 4th and 5th decades of life. In terms of its presentation, comes up with a thunderclap headache, which, as we described, is a headache that reaches maximum intensity in just the first few seconds or first few minutes of the headache starting. Some patients may also lose consciousness at the point when they have this thunderclap headache. And as pressure increases, they could start vomiting, as blood tracks into the subarachnoid space, could irritate the meninges, and they'll either complain of neck pain or neck stiffness, but they could also have a fever. So let's say a patient comes in, they have a fever, they have neck stiffness, and they have a headache. You might be swayed to think this is just a meningitis, but if you take a good history in terms of how the onset of the headache was, that will push you towards suspecting a subarachnoid hemorrhage. So focal neurological deficits may occur, but most times they will not be present quite early on in the presentation. So this is a patient who's actually going to come to the facility whilst they are walking without having any limb weakness, okay? No weakness in their hand or their leg. In terms of the investigations you're going to do, so CT is quite sensitive in the first 24 hours, and essentially you want to see evidence of blood in the subarachnoid space. So we know that blood on CT looks white. So this has a bad name. It's called the crab of death sign. So this white hyperdensity there is blood. So within the first 24 hours, you might be able to see this. But we know with some of the challenges we have with our patients, they may take time to come to the facility, or we may not have provision for a CT at the facility, and so you have to refer this patient. The sensitivity of finding blood beyond 24 hours decreases, okay? So you might not be able to see it as hyperdense. But if you've taken a good history and you're suspecting that this could be a subarachnoid hemorrhage and CT is not suggestive for it, you proceed to do a lumbar puncture, and you're looking out for an elevated opening pressure, trying to see if there's evidence of red blood cells in the CSF, or as the red blood cells are breaking down, you can have xanthochromia as well. But if you're looking at this panel of the CSF findings, you could have an elevated white cell count, and the glucose might be slightly low, which might sort of seem like it's actually a bacterial meningitis of some sort. But that's where a good history comes into play. Okay. And then in the fitting patient and where facilities are available, you could do a CTA or CT angiogram to find evidence for an aneurysm, and that also helps to plan out the management. In terms of the complications, if the aneurysm is not secured, there is a 20% chance that the patient might bleed again within 2 weeks. And we know that subarachnoid hemorrhage comes with it a higher mortality. So if they have a rebleed, that will double their mortality. Then as you have intraparenchymal extension of the blood, patient could have focal neurological deficits, which might start early on, but most times they come up with vasospasms. So this is where the blood vessels start to sort of vibrate or spasm, and during those episodes, the areas of the brain that are distal or further from where that spasm is happening could undergo ischemia. So this is a patient who had a thunderclap headache 7 days ago, and now they are coming in with weakness on one side. And that is why early identification becomes very important, because this is something that you'd want to prevent. Then they could have hydrocephalus. Some can also have seizures at the point of presentation, or they could develop diabetes insipidus. In terms of management, you want to keep their blood pressures not too low and not too high, because the higher the blood pressure, the more likely they might continue to bleed. You're going to recommend bed rest for them, elevating the head just to help prevent increasing intracranial pressure. Then you want to start your nimodipine as soon as possible. So this is something we tell the patients to say, even as we are suspecting they have a subarachnoid hemorrhage, if there is in any way a delay in confirmation, start your nimodipine very early. So this is given 60 milligrams every 4 hours. And this means if, let's say, someone starts at 10 hours, they're taking at 10, 14, 18, 22, and 02. The patient will have to be awoken to make sure that they're taking the medication, and they take this for 21 days. This is recommended for aneurysm or subarachnoid hemorrhages. So this is the bare minimum of what we should offer the patient. Then we also, just to prevent development of vasospasms, you want to make sure they're euvolemic, they have a normal HB and hematocrit, and surgery, if available, or you are in a place, a facility or a center where you have access to neurosurgery and they're able to do this, surgery can be done to secure the aneurysm. And post surgical intervention, you would want to induce a bit of some hypertension, because hypotension can also push them towards vasospasms. In terms of the prognosis, so 1 out of 5 patients will die before they actually get to the hospital, and about a quarter of patients will die from their first bleed. So you can imagine if they do have a second bleed, mortality is quite high. And of those that survive, about 50% go on to have permanent neurological deficits. So is the thunderclap headache always equal to subarachnoid hemorrhage? The answer is no. Okay, even just a stroke could give you a thunderclap headache. You could have reversible cerebral vasoconstriction syndrome, a CVST as we spoke about, or a cervical artery dissection, or someone bleeding into the pituitary gland, or less blood going to the pituitary apoplexy could cause a thunderclap headache. And then second cause of a secondary headache, so you could have what we call giant cell arteritis. So this is something that's more common above the age of 50. So it's going to be an older patient, and it's more common in females than in males. So they'll typically come in presenting with a unilateral or bilateral headache, but they'll have some scalp tenderness or pain or tenderness around their temporal regions. There could also be some jaw claudication. So as they eat or as they talk, they could have that discomfort. This is also more common in patients who usually have joint stiffness, muscle aches, and they have a polymyalgia rheumatica. The complication of this is that if a patient comes in and you do not figure out quite early, most patients will progress and end up having blindness, and this is usually permanent. Okay, this is expected in half of the patients that are treated, and in about 25%, it will be blindness in both eyes. So it's quite important as you're doing your examination, check for scalp tenderness as well, and as you're taking your history, look out for that jaw claudication. In terms of investigations, you ask for an ESR, and it's typically quite elevated. We do not usually have facilities for doing a temporal artery biopsy, but where possible, you can do it. But even if it is normal, that does not rule out a giant cell arteritis. And on physical examination, you can sometimes see the thickened temporal artery. In terms of treatment, steroids are going to be the mainstay of treatment. So initially we start with quite some high doses of the steroids and then switch them to oral steroids. And you're going to be tapering those down depending on the ESR. So you'll be doing the repeats, okay? And then the last secondary headache that we'll look at today is the idiopathic intracranial hypertension, previously called pseudotumor cerebri. So this is far more common in females than in males, and it's usually going to be a younger female. So they'll come in presenting with the sort of a global headache. It's often worse when they're lying down. So maybe they say they have their worst headache early in the morning, or a headache that's waking them up. They'll also have this pulsatile tinnitus, so it's ringing in the ear. They could have transient visual obscurations. So these are sort of temporal episodes where they have a loss of vision. So it can be after bearing down or after a sneeze. They have for a brief seconds, may either be unilateral or bilateral. So in one eye, they lose their vision, or in both eyes, and it just lasts for a few seconds and the vision gets back. But over time, they could also progressively be losing their vision, and it's usually from the sides coming centrally. They could also report double vision. In terms of the risk factors, it's usually patients who are obese, especially if they rapidly gain weight, or patients who have cerebral venous sinus thrombosis, or a patient that you're treating for some autoimmune disease. You started them on high doses of steroids, and as you are coming downwards, as they are withdrawing from the steroid, could push them to develop idiopathic intracranial hypertension, excess of vitamin A, so hypervitaminosis A, or in patients who are on treatment for their acne, a lot of them are derived from 13-cis retinoic acid. So some of those drugs could push patients to developing IIH or tetracycline as well. In terms of the examination, when you do a fundoscopy, you expect to find papilledema on both sides. They'll have the 6-hip cranial nerve pauses, especially if the pressures so high. There are the constriction of the vision and a decreased visual acuity. So as you're assessing for that, you find limitations. In terms of diagnostic workup, when you do a CT, this is what you expect to find. So you have a flattening, okay, of the optic nerves there. You also have a thickening of the optic nerve sheath, and this tortuosity of the optic nerve as well. Then this is an empty cellar sign, okay, that's on MRI. And when you're doing your LP, you expect them to have quite elevated opening pressures. In terms of treatment, you can use acetazolamide. We typically start a little lower than, so about 500 BD, which would be like 1 gram in a day, and then titrate upwards. And if need be, you could add some furosemide as well. But for those who are quite obese, just a weight loss alone has been shown to also decrease or at least be curative for IIH. For those where there's an acute vision loss, it's indicated for you to do a lumbar puncture just to limit the pressures by getting some CSF out. Okay. You could do optic nerve sheath fenestrations, make little holes in the optic nerve sheath, or you could ask neurosurgery to put up a ventriculoperitoneal shunt. Okay, so when do you refer a patient you're suspecting has a secondary headache? If you have not established the cause for that secondary headache, then it is best that you should refer the patient. Okay. So the take-home points essentially is that the presence of red flags, which we're going to remember by using the SNOOP P4 acronym, presence of any of those features will point us towards a secondary headache, and that unlike primary headaches, imaging is indicated in secondary headaches, and early referral prevents complications like we've discussed. For a subarachnoid hemorrhage, you want to prevent them developing focal neurological deficits. So early referral is very important. At this point, I'll hand over to Teresa.
Thank you so much, Mr. Liamba, for that wonderful presentation. At this point in time, I'll just open the floor to any questions, any contributions. If you have any questions, you can still type them in the chat box. We'll be able to see them. So feel free to just unmute your mic and allow me to also just reintroduce our panel of experts. Dr. Emily White, Dr. Chomba Mashina, and Dr. Frighton. Yeah, well-able neurological consultants.
Yes.
So any questions? All right. So if there are no questions, I'll just introduce Dr. Emmanuel Piri, who's going to give us today's case presentation. Dr. Emmanuel Piri.
Good afternoon.
Afternoon, how are you?
I'm all right, thank you.
All right.
Okay, I'll be sharing my video.
Could you just speak a little bit louder?
Yeah, are you able to get me now?
Yes.
Okay, thank you so much. We'll be sharing my screen. Okay, is my screen visible?
Yes, it is.
Okay, thank you. So just a correction, I'm not a doctor, I'm a medical student. So my name is Emmanuel Chileshapiri, and I am a final year medical student at the Cobalt University School of Medicine, based in Angola on the Cobalt province. So I'll be taking you through this case presentation. So this is a history of a 15-year-old boy who came in from a local clinic within Yola to Arthur Davidson's Children's Hospital with presenting complaints of a headache for 7 days, 1 week, as well as a right arm numbness, which was just for a day. So prior to this, it reported that he had been onset severe headache, which was encompassed with 1 day history of right arm numbness. So over the week, the patient experienced intermittent pounding headaches, which were more predominant on the left side, non-radiating, and would be worsened by physical activity such as playing football. There were no associations with difficulties with in terms of light, no nausea, vomiting. Patient also reported that the headache was slightly relieved by taking Panadol as well as ibuprofen. There was no history of convulsions, no loss of consciousness, visual disturbances, no history of trauma or fever that was reported. Further on the history, so this was a 2-episode headache that was reported. And on the first episode, there was experiencing of transient right hand weakness with difficulty speaking, lasting for several hours and resolving afterwards completely. And prior to admission, that was on the day of the admission that the patient came in, and this was a second episode of a headache. So patient experienced this headache that worsened and also reported the transient numbness in the right arm as well as the leg, which also resolved spontaneously after a couple of hours. There was no facial drooping, gait disturbance was not present, no speech difficulties during these second episodes. So there were no recent infection, rash, ear discharge, chest pain, palpitations, or any other complaints that were reported. And review of system was as well non-remarkable. Patient had a non-remarkable past medical history. There were no chronic illnesses, no past medical or surgical history that was relevant, and the HIV status was unknown. For the drug history, patient had only been taking the Panadol as well as the ibuprofen to relieve the headache, not on any chronic medication, and there was no history of taking any steroids, herbal drugs, or any non-drug or food allergies that were reported. For the neonatal as well as the childhood history of this patient, so this is a patient who was born at term via vaginal delivery. There were no resuscitation that were done at birth, and no neonatal illnesses that were reported. The patient had a good neonatal as well as childhood history in terms of nutrition as well as developmental milestones. There are no any remarkable familial history, no similar complaints are reported, and no chronic illnesses in the first degree family, as well as any sudden deaths that were reported. All the patient's parents as well as siblings are alive and well. The patient was not a smoker, not an alcohol drinker, no recreational drug use, IV drug use. This is a patient who attends school and interacts well with peers. So in terms of the neurological examination that was done, during the examination, the patient had been fully conscious, alert, very calm, very cooperative, oriented to time, place, and person. The patient was able to talk properly and as well as obey commands. There was no speech or any comprehensive speech deformities, and cranial nerve examination were intact. The patient had normal muscle bulk, and as well as power was a fifth in all limbs, and positive deep tendon reflexes, no corners in all limbs. The sensory system was responsive and intact to light touch, as well as pain and vibration. And the patient had an intact proprioception. There were no gait deformities that was noted, and coordination was well, no dysmetria, no intentional tremors that were seen. And meningiscal signs were also examined, and they were negative. On the review of system, it was as well unremarkable. So trying to localize the patient's lesion based on the reported history and the physical examination, just from the one of the most 5 important things that noted from the history is severe headaches that had been present for 1 week, worsening over a couple of times, as well as completely resolving. And also noting that this is a patient who had these resolved focal neurological events that were more prominent on the right side. So on localization, noting that the neurological deficits that were presented, or rather mentioned, were more prevalent on the right side, and understanding that understanding our neural pathways, motor and sensory pathway, also putting into consideration the decussation of nerves at the medulla. We know that this was most likely a neurological dysfunction that was more prominent on the left hemisphere. Also, one thing that noted to try and localize this neurological problem was that trying to understand whether or not this problem was associated with the brainstem or more with the cerebral above the supratentorial, is to note that this is a patient who had sensory and motor dysfunction, as well as speech problems with intact cranial nerve. And so this is pointing to something that is more related to above the supratentorium. So there was no association of or involvement of the brainstem. And another important thing that also helped to try and localize this lesion was that trying to understand whether or not it was involving the cortex or something that was within the internal capsule, was that this is a patient who had dysfunction presenting with dysfunction in terms of the face, the arm and the legs. And also this was involvement of the motor as well as the sensory cortex, which we note that these are areas that are mainly supplied by the left cerebral artery. And so it also all pointing to a left hemisphere, which probably could have been either a ischemic or hemorrhagic cause. And the differentials that we derived, or rather what came up from the history and the physical examination, were the following. So was suspicious of probably a transient ischemic attack, reversible cerebral vasoconstriction syndrome, a focal cerebral arteriopathy or post-infectious cerebral arteriopathy, or perhaps a primary headache, a migraine. But then we note that from the presented features that we have already mentioned, this was rather more pointing to a secondary headache. And this is, as also mentioned from the presentation, is that primary headaches would rather not be associated with structural or vascular problems as compared to the secondary headaches, which we can note from the history that they were identifiable neurological deficits that were presented. And from our case, this was the red flags that were presented were the right weakness, the numbness, as well as the speech difficulties. And so this is why particularly this case presentation was pointing to a disorder which is a headache associated with secondary causes. In terms of how the patient was managed, so this patient was admitted, there was pain control done, and then also maintained good hydration, encouraged bed rest, consistent motor neurological status monitoring, as well as the vitals and any symptoms. Blood work was done. In terms of food blood count was done. We did also a glucose tests, electrolytes test, the lipid profile, the coagulopathy, coagulation test was done, as well as the baseline in terms of the liver function test and the kidney function test. MRI was prioritized to try and evaluate for cerebral vasculature, as well as an ECG and echo to rule out any cardiac sources of an emboli in case of a stroke or any ischemic cause. And so also the patient was put on some calcium channel blockers. I think that was an nimodipine to relieve, as already mentioned in the presentation, when it comes to secondary headache presentation. And so in terms of, because this patient was prioritized to specialists' further evaluation, and yeah, this is more of what was done, particularly for this case. Thank you. If there are any questions.
Thank you so much, Dr. Emmanuel, for that presentation. The floor is open to any questions, suggestions, or contributions. So any questions? I'm assuming Dr. Emmanuel did a very good job since there are no questions. Any contributions, concerns? Please feel free. You can also use the chat to just write down your question. Okay, so I'll just read out one question then. Though this question is not for the case presentation, this question was for the first presentation that we had. Okay, so the first question is, for the secondary headaches that can be mistaken for meningitis, can we still start antibiotics? Okay, so thank you so much, Chawanango, for that question. I think it reads, for secondary headaches that can be mistaken for meningitis, can we still start antibiotics? So I'll allow the panel of experts to just come in for that question.
I'll come in for that question. Thank you much. So meningitis is considered a neurological emergency, and empirical treatment needs to begin as soon as possible. And I think before you even confirm, you are supposed to start on empiric treatment with broad spectrum antibiotics. I think you are justified to cover the patient on antibiotics until you prove otherwise. One of the things that must be known is conditions like subarachnoid hemorrhage can sometimes actually mimic meningitis. Sometimes subarachnoid hemorrhage can start with, the intermittent headaches that are not very severe, and ultimately you end up with a headache that is severe. Headaches that are known as sentinel headaches. And so sometimes that could be a bit confusing, and it would be important for you to cover the patient until when you do imaging or when you do the lumbar puncture. If it turns out to be subarachnoid, then potentially you can stop the broad spectrum antibiotics, and vice versa. You could be thinking it's subarachnoid and then it turns out to be meningitis. I hope that answers your question. Thank you.
All right. Thank you so much, Dr. Mtete. Chawanango, I hope you're clear on that. So I'll read out the next question. The next question says, what explains the dysarthria in this patient? I think this question is from the case study. So I'll still throw it back to the panel of experts. What explains the dysarthria in this patient? So if Dr. Chomba or Dr. White is in the house, you're free to take up that question.
Hi, Teresa. How are you?
Hi. Very fine, thank you. How are you?
I'm good. Thank you so much. I think I'll start off by stating just how fantastic a job I thought Emmanuel did with his case. I think that was a very, very good case. It was a very good example of a patient who presents with headaches, and I think the approach in the case was done very, very well. So just before I go into the question, just to congratulate Emmanuel for that and encourage everyone to think up cases in their sites that we can bring to this platform for discussion. I think there is a lot of interesting neurological signs and symptoms in the patient presented. And in one of the slides, Emmanuel mentioned about how when you are thinking about a case in neurology, you always have to think about localization and where this could be coming from. And we don't really have any confirmatory imaging, but I think there's a lot of information and clues even when you don't have imaging. So when you think about weakness in the upper limb that the patient had, a weakness on the face on one side of the body, like we mentioned in the very first talk on approach to neurological cases, we think of that being in the brain, somewhere in the brain. And when we think about where in the brain it is, because the weakness in the body was on the right side, then we think about it being on the left side. So on the left side, we also discussed that in the left side of the brain, you can try to think of about 4 places that could be. So it's either in the cortex, in the subcortical territory, in the cerebellum, or in the brainstem. And in this case, because it was on the left side, if it was cortical, we would expect the patient to have aphasia. So there would be complete language deficit with the patient if it was cortical. But in a case where it's subcortical or somewhere within the brainstem, there is no cortical involvement, so there's no aphasia. But what the patient can get in cases like that is rather than only a language problem, or rather than a language problem, they can get a problem with a speech only. And that arises because of the weakness in the tongue. The same way you have weakness in the hand, you can also have weakness in the tongue. And this weakness in the tongue makes it difficult to pronounce and make words, and you end up with what we call dysarthria. The patient sounds inarticulate. So that could be one of the explanations if we think about localization a little bit more with this patient, that the same kind of weakness we're having in the face and the arm could be the same what we're having in the tongue, and that the tongue makes it difficult to state words and to pronounce them clearly. So that could be one of the potential causes of the dysarthria.
All right. Thank you so much, Dr. Chomba, for that. Mlanga, I hope that question has been answered. If there are any more questions, please feel free to just type them in the chat box. If you can't raise your hand, or if you can't just disrupt me while I'm talking, feel free. Yeah. Thank you so much, Dr. Chomba. All right, so I'll just invite Dr. Mtete or Dr. Emily to still just comment on the case in case there's something that you would love to say.
Sure. Thank you so much for having me. That was a wonderful case presentation by Emmanuel, and I also appreciated the localization and the detailed thinking there. I do see there's another question in the chat. I could go ahead and answer that one. It's asking, are there any times when we should consider antiviral therapy for secondary headaches, and which antiviral therapy would be the drug of choice to start as you investigate the patient? And that's a really important question. I want to emphasize that in addition to the antibiotics, such as ceftriaxone, maybe vancomycin if available, and ampicillin if they're immune compromised or elderly, also very important to start antivirals. Usually the drug of choice would be acyclovir at a dose of 10 milligrams per kilogram 3 times a day. And this one would cover for HSV encephalitis and is also extremely important, especially since HSV can progress very quickly. So equally an emergent therapy is starting antibiotics. Essentially, that should be started at the same time as well. So really good question.
Thank you so much, Dr. Emily, for that. So Kayanja, I hope that has answered your question. I'll still call for more questions so that people can learn. And if you're not sure, so that you can get clarity. Yeah. Any questions or comments? All right,
I
as
want
well.
to find out.
Yes, please. Just introduce yourself and
I am Wanangwa Piri. I am a GRM at St. Francis Hospital.
okay.
Yes, I wanted to find out. After I heard antiviral therapy, it reminded me of yes, and then we said people with vascular problems can also have headaches. So if let's say we have a patient who has got KS, it's diagnosed, and then they start complaining of a headache, are we just going to blame the KS and say, okay, they're having the headache because of the KS? So in that case, we're still supposed to start from scratch and fully investigate the headache, or just say, okay, you have a vascular problem, which is the case. Most likely, it's the case that's causing the problem.
Okay, so could you just repeat that question again? Sorry. Just be a bit louder this time.
It must be the microphone. I was saying, in a case where I have a patient who's got Kaposi sarcoma, and from the lecture, I've heard that people with vascular problems can have headaches. If a patient has Kaposi sarcoma and they start complaining of a headache, are we just going to say most likely it's the KS, or in that case, we're supposed to start from scratch, so to say, and investigate the headache, or we can just check it off to the KS? And if we are going to say, okay, it's a case that has caused it, is treating the case going to be enough, or there is something else we can do in that case?
All right. Thank you so much for that good question. I'll still transfer it to the panel of experts. Yeah.
Let me try to make a contribution on this one.
Yes, please.
So I think one of the things we may have to consider in this case, Mr. Perry, is the fact that just by virtue of the patient having case, I think, as you can agree with me, most of our patients with Kaposi sarcoma are those that are immunocompromised. And so I think that's a red flag already. And in a patient with compromised immunity, we potentially have a lot of causes of secondary headache. And so this is a patient that I may need to reevaluate neurologically and pursue a number of investigations to rule out secondary causes. And if the case is HIV related, this is obviously stage 4 HIV, and we have to be concerned about all potential CNS opportunistic infections. And so if you feel for a patient like this, there are some things that you may not manage to evaluate neurologically. I think this is a case that would potentially benefit from a referral to a specialist. Thank you so much.
All right, thank you for that contribution. I hope that response was very clear. All right. Unless there's any more question or any contribution, just an announcement, kindly take part in the survey for the Neurology Made Easy Echo. The link is in the chat box. We encourage you to just take that survey. It's not going to take more than 2 minutes. Yeah. Any other questions, any contributions before we come to a close?
Thank you. I actually wanted to just add a few more red flags that should be considered when we look at secondary headaches. So SNOOP4 has actually been expanded, and there are a few other things that you may want to look at. And I think one of the P's is, pregnant women and those that are postpartum, patients that may have eye pain. There are some neurological conditions where patients may just feel eye pain. For example, multiple sclerosis with optic neuritis, patients may have eye pain on looking to the sides especially. So all of those are now considered to be red flags. A very interesting topic to discuss, really. Dr. Diamba, thank you very much.
All right, thank you so much for that addition. Okay, so any other addition, any contribution? All right, just again, kindly take part in the survey for the Neurology Made Easy Echo. And at this point, allow me to thank the panel of experts and also the presenters, Dr. Nyamba and Dr. Emmanuel. Thank you so much for those wonderful presentations. And thank you so much to the panel of experts for very, very good direction contributions. And allow me to just thank everyone for participating, and just an encouragement to continue participating. And if you are shy to speak, just type your questions, your contributions in the chat box. All right, so
Teresa, sorry to disturb. If I can quickly just add on about the survey, as you said. Thank you very much. This was really a wonderful session. For all the participants, when you complete the survey, please just remember that you need to submit the survey and the quiz. So you have to go back to the survey page to submit. There are 2 different pages. But the other thing to say is if you don't want to do the quiz, you can just do the survey to give us more information about the participants, because I know maybe some people are not keen to do the quiz. So you just, as long as you do the survey, then we'll greatly appreciate. Thank you.
All right, thank you so much, Dr. Sukile. All right, thank you so much, everyone. I was your facilitator, and have a good day.